And it is our great pleasure to talk to you about A View from the Peak, ongoing lessons learned on behalf of the EIIC Knowledge Management domain. So I'm Corrie Chumpitazi, Associate Professor of Pediatrics at Baylor College of Medicine and Texas Children's Hospital, where I co-lead the research domain and EMSC Scholars Program with Dr. Stanley. And then from a knowledge management standpoint, I have the great pleasure to work with Dr. Saidinejad, who's Professor of Clinical Emergency Medicine and Pediatrics and Director of the Lundquist Institute for Biomedical Innovation at Harbor UCLA, where he's Director of Patient Experience in the Department of Emergency Medicine. And then Marc Auerbach, who's Professor of Pediatrics and Emergency Medicine at Yale and Director of Pediatric Simulation at the Yale Center for Medical Simulation. The three of us are in close communication weekly, typically daily, and sometimes share the same brain. So we'll really make this an interactive session for you where we can have an opportunity to generate some ideas and show you what we've been up to. And then we can't do it alone, and we'll have an opportunity to introduce you to our rockstar team at the end of this presentation. So our disclosure is as states, and then our objectives for this session are to talk about the features that contribute to a needs assessment and evidence-based synthesis to guide content creation, and how might we do that or take the things you are working on to that next level. We want to have you commit to contributing to the creation of content, and then design a dissemination plan for that content. So when we look at the outline, here's what we're going to do, and we really want to make this an interactive session. So we want you to type in the chat, to unmute yourself when we have an opportunity to, and really think about how we can take that content curation and collaboration and really help further hit the eyeballs of your target audiences, and then talk about some of those opportunities for our grantees. So when we think about where we came from, the National Resource Center was established in 1991 when the Maternal and Child Health Bureau, under a cooperative agreement, brought that resource center to DC. And it really served as an opportunity to think about the project development, needs assessment, coalition building, public policy, and the community engagement for that. Well, with the iteration of the Emergency Medicine for Children Innovation and Improvement Center, version 1.0, as I call that, we moved a lot of those resources here to Baylor College of Medicine, where we worked really closely with our website team, with the Center for Innovative and Collaborative Technologies. So you'll hear that referred to as CCIT, and we really went through a lot of older documents, and we're reiterating and revolutionizing how we could get that data out there. And you got to see some of that visualization that Rachel Alter and Dr. Rundle had a chance to show you earlier. And then with version 2.0 really and version 1.0 really bringing that QI methodology to the forefront, and getting people linked with the IHI modules, and thinking how we do really iterate with quality improvement to that 2.0 version, where we really are looking at that implementation, innovation, and analytics, and how do we reach and disseminate this information and the amazing work that you're doing. And so what brings you here? What did you guys see in the title that got you excited? What content are you working on? What are you planning? With the different opportunities we've had a chance to hear throughout this meeting, where do you want to go? Anything in particular that comes to mind? I see some disaster folks, some trauma. Feel free to type in the chat or unmute and talk about what you want to work on it. And then what skill set? Where do you need the help? Do you need help with design, education, videos, podcast? Pat?
Yeah, thanks, Corrie. You saw me. My name is Pat Frost. I'm the Vice Chair for the National Pediatric Disaster Coalition. We've been working in this space since 2015, and really have noticed through our experience in both real world as well as supporting information sharing, the challenges that the end user faces to just find information and to make sense of it. And so we have, in our small but I think important way, have acted as a resource to help people navigate that. And so I certainly have been involved in people on our listserv, reaching out to us and say, I'm trying to do X. I'm trying to work on search. I'm trying to do the pediatric annex and stuff. There is so much information. I'm completely overwhelmed, or I have no idea where to start. And for me, it has been very important to actually set up a phone call with these people. So I have an understanding of their local circumstances. And that way I can curate some appropriate resources that are not too overwhelming, but will help get them started, and then invite them to reach out to us again, or join our listserv, or, look at our website for the links to other trusted sources. So we're kind of like a conduit, as far as that. We do in terms of just in time. And I mean, personally, I think I have the biggest Dropbox on pediatric disaster in the world. I'm not kidding. I've been collecting this stuff since 2015.
And that's phenomenal. And I hear a lot of really amazing tips in what you said. I think one of the first things you said is you listen. You're not just asked a question and you immediately respond and say, oh, here, you need X, Y, and Z, but you're listening to the folks, you're understanding a little bit more about the scope of the project, and then what really is going on, where do those needs lie?
Yeah, I think the other part that's really important to me is that by reaching out to them and having a conversation or setting up, I mean, now we have Zoom, I'm actually helping build a relationship, not only with, the National Pediatric Disaster Coalition, but to all these other, resources. And this is, everything in disaster is about relationships. This is what I have learned, in this space. And that is the most important thing, because if I don't have the information, I know who to ask for the information, and I can make a call out for that.
Yeah, exactly. And I think too, understanding. So if we'll move to that next slide, and knowing who to reach for what. And so what is that problem you're having to solve? If it is, a toolkit for COVID response, for whatever it might be with disaster, whether it's a state partnership program that you weren't aware of some of the resources from in that pre-hospital PEDS Ready toolkit that we just heard about. What is that problem you're trying to solve, and how do you drill down to that? And so what we're really here to help you with is doing the randomized control trials, doing that evidence synthesis and creation, and getting that data is hugely important, as we very well know. And so the work that PCARN and NEDARC and the TI grantees can do, but how can we really bridge that gap? If it's really taking 17 years on average to get that knowledge out there, how can we shorten that? And we know that that model for improvement can really help us there. Doing our plan, do, study, act cycles and try to use those to iterate and rapidly work with the different organizations to get that information out there. And then as Dr. Auerbach just put in the chat, building those relationships on a local, a regional, state level is really great. And then how can we, as a KM domain and the face of the website that is utilized by throughout the EIIC and much of the EMSC space, how can we help you? So you did a little bit of digging in creating that phone conversation, then with that identifying of the problem, but then how do we get to that targeted needs assessment? And how have you done those for the projects that you've been involved with? What routes have you used? What have you found helpful? What has worked for any of you participating in this call? We heard yesterday a little bit about the mental health needs assessment. I don't know if Mo or Mark, you want to touch on how you decided to set that needs assessment up from that standpoint.
Yeah, thanks, Corrie. I think one of the important things about the needs assessment is to have people who know what the needs are involved early on and have it be from multiple different perspectives. So when we were looking at this, we gathered a multidisciplinary group of individuals with all having stakeholdership in mental health. We looked at psychiatry, psychology. We also looked at emergency medicine. We looked at leadership from nursing, leadership at pre-hospital level, the rural health, social work, patient and family representations, because you really need to get the perspective from all of the different possible individuals and organizations and groups for this, for whom this content may be useful at the end. So it is important to have a deliberate process of involving as many stakeholders as possible, without having, of course, the group be too big.
Yeah, and that's the thing too. You know, you can say, me as an ER physician, what I think the needs are, but I don't practice in, you know, if maybe it's a community hospital, or how do we access different resources. You really got to get the information from the people who are going to be your end user, as you hear us talk a lot about. So let's move on to that next slide. And just talk about our knowledge to action pathway. So once we've identified that problem, we go ahead and look at that. And this is our framework for how we've developed it. Marc, do you want to talk a little bit through this infographic?
Yeah, I think just recognizing and the other researchers in the middle there, where they are going through efforts to conduct research, that research is being synthesized into evidence-based practices. And really our goal is sort of to take that down into that smaller part of the pyramid, where it can be useful resources for frontline providers and or families and or patients that can be digestible. And then the outside cycle, I think, is a really key element here, which is not that you create something and that's what it should be forever, but that you create something, get feedback, figure out how you're fitting your learners' needs. And that's where that targeted needs assessment is really important, because I think we all know that there's a mental health crisis right now, but how do you fit the different needs of each of those individuals that were mentioned in that plenary and do it in a way that they'll actually consume the content, but then demonstrate improvements in knowledge, skills, and most importantly, practice.
I agree. So don't go too fast, take the time and really put those resources into the needs assessment, and then make sure they're representative of the audience that you're trying to reach. And if not, then maybe they need a different needs assessment for a different area. Maybe Alaska's needs are different than Texas needs, maybe not. But thinking about those items, I think those are great points. Any other points from folks on the line in regards to needs assessment?
Yeah, so Pat put a comment in, and I think this is a great example of academic resources, and we've seen this even with disseminating PCARN content, and we've heard this from some of our state partnership grantees and EMS providers, that how we distill down that academic content probably looks a little bit different if it is for an academician, even an academically oriented pre-hospital provider or hospital provider versus a community oriented provider. I think it's the packaging and sort of what you're wrapping it up in and how you're presenting it, and we'll get to that later, but that instructional design or delivery can be adapted to have similar goals and objectives. And certain individuals might want to know the table 1 of the RCT. Other individuals might want to know, just tell me what to do. I don't want to screw up. I want to save this kid. I don't want to kill him.
Hey, Marc, can I just make one more comment? One of the things that I have found to be absolutely essential to getting the process started is to ask questions about how well or how much does the individual know about the children in their community. You know, the numbers, how many kids go to the emergency department, how many kids are in, the pre-hospital, how well, do they have pediatric protocols, that type of thing, because there is so much variation across the country. If you don't know what your lay of the land is, you may be off on a tangent that is going to, make you kind of go in circles instead of really getting you on a path to accomplishing something operationally. And so asking those questions and having those people do a little research about it. And I've shown people examples about how I did that in my county, but also how other people are doing it in other counties so that they have a real, tangible example.
Yeah, Pat, I think it's important. And what we tried to do is make it really easy for them to do their job well. So one of the things that I'd like to try to leverage is even things like the state hospital-based pediatric readiness survey, and hopefully in the future, the pre-hospital, and the epidemiology. I think it's shocking to hear how many kids are in your state, how many of those present to non-children's hospitals, how many of those are cared for by EMS providers. So thank you for that, Pat. My comment would be perhaps we can even, spoon feed it to them so that that pediatric champion can pitch that to their group.
Yeah, and I think exactly like you said, it's such great work by so many folks on this phone to call with getting us the data to be able to understand that, and so starting with that data is extremely important. So then, as we're going on, moving through our cycle, we look at the different target audiences. Who is that? Who is your viewer? Who is listening? How do they like to receive information? We talk about it a lot as personas, but it's really just that folks that will be consuming that content. And so then we did want to just touch on a few of those resources moving forward to the next slide, where how do we find out what we want? We talked about that with our needs assessment, but then then how do we get them the information? So how do we, as the evidence-based outcome center and our Marc Vasquez, who you'll see a picture of at the end, with our knowledge brokers, how do we really look at the data and help support that? So next slide, and one more. Yeah. And so how do we find that truth? How do we really help support that? So, we'd love RCTs, those are randomized control trials, or even systematic reviews of those high quality studies to really try to make some of that decision-making process. But do we really need that in all cases? I don't need, I'll take an observational study to say that I need a parachute to jump out of a plane. I don't need a randomized control trial to answer that. So what we're doing here at Baylor College of Medicine in our node is really working with our investigative team, with our knowledge brokers, assembling the evidence, working with our content experts, and able to really drill down on these contents. So if there are questions that need a robust literature search, reviewing of the literatures, thorough grading, and those kind of things, then we can start with you from scratch on that. A full systematic review does take about a year or more to do. And so thinking about, do you really need that? Or might we be able to help you with like a meta-analysis of some of those studies, especially if your outcomes are mortality, time to hospital discharge, or survival to discharge, if they're binary outcomes, we can help do that. And so on that next slide, we talk more about that literature review, where we help with that, conducting that research. We can use whichever databases you already have created to work with, and then help review and refine that work so that we can either get that back to your content experts to say, hey, does this look like it should be? Like, for example, with our algorithms we're creating through the PEAK toolkits, we really want to start with that algorithm that will apply to both pre-hospital and hospital-based personnel that's really high quality evidence-based. And we use that algorithm as its kind of standard of truth from which we build on the rest of the resources we develop. So whether that be for an academic publication or for publication on our site, we really do have our research and our guidelines rooted in the science. So I just want to tell you guys a little bit about that process that's going on behind the scenes. And we talked about, Dr. Ranis and several of the talks this morning talked about SMART objectives, making sure that when we're looking at those questions that we want to answer, we want to educate around, that we're using SMART aims that are specific, measurable, achievable, realistic, and time bound. So that's just a little slide to remind us of that. And then looking at our algorithms. And this one's undergoing review. Right now, this was our first algorithm for status epilepticus that we were able to do in collaboration with Trek Canada, which has been a phenomenal partner. And so these are the types of algorithms that we're looking to create and develop. So systematically review and using the evidence grades and those kind of things are a fundamental core principle within the EIIC and the EMSC. And so when we're thinking about those questions or education, I was rooting that evidence in the literature and in the studies. All right, Mo.
Corrie, one quick comment on the evidence synthesis that was striking to me is I had approached this from implementation science. So people aren't doing something, we want them to get them to do it. I think a fascinating thing has been de-implementation. So seeing that people are doing things and having them change that practice. And even if the evidence is there for something like status epilepticus, changing their frame to say, okay, I'm not going to use phenobarbital anymore if they've been doing it for 20 years, it can be a big challenge. And I think this is where Pat's relationship building and having influencers on podcasts and things like that has worked really well for us. Like, it's one thing to hear it from the three of us, it's another to hear it from someone like Marianne Gaucher-Hill.
Absolutely. Thanks so much, Mark. Thank you, Corrie. I'm going to talk a little bit more about the world of content. So as you know, the biggest challenge is if somebody asks you, hey, do you have any content on this? Or can you make me specific content on a specific subject? And as Pat had mentioned, it's an overwhelming world out there of all the different content that's out there. And every content isn't right, isn't what your audience needs, is not what you need, but how to choose. I mean, that's a very difficult task, right? Because there are content that are evidence supported, are amazing as they are, they speak to your right audience, and rarely you get those, but when you get them, you share them to the audience that you can. But oftentimes, you feel like I don't really see anything that's quite what I want. So I am sort of feeling like I have to create my own. So please feel free to just type in chat if you feel that urge that you need to create your own content because you feel like there's nothing out there. And then we can kind of have you on mute and explain that a little bit or kind of tell us a little bit more. But that's one of the challenges with when you're having to look at other people's content. Obviously, the problem with other people's content is you might have two different sources of content. You like them both, but they're not consistent with each other. They don't speak to the same exact reality. There is different type of messaging than what your audience needs. There may also be quality issues with the content. They may be beautifully done with the high definition cameras, but then the content is not really evidence supported. Sometimes all you need is a pocket card, but the content is a 1.5 hour video. So there are also kind of compatibility issues and the concept of having the right content for the right audience. And this is the quote attributed to Abraham Lincoln, of the people, by the people, for the people. So for example, if you're trying to build a nursing tool for some kind of a nursing competency, wouldn't it be great if the person who's narrating it was actually a nurse and not somebody who doesn't look like a nurse? So it's always important to include the stakeholders. And we always talk about having the end users, whoever our target audience is, engaged early on and have them be involved in the process of creating the content with us. The challenge with making your own content, obviously you can tailor it to where you like it. You can plan it, you can develop it, you revise it as many times as you want. You have a team of people that look through it, approve it. You make it perfect, you publish it, and then you can measure it. So all of those great things about having your own content, but the considerations that you have to give when you have your own content is, of course, time, right? It's very time intensive to create your own content. You may not have the expertise or perhaps not even have access to the expertise to create that content that you like. You may not have the technology to do this. Maybe you're not tech savvy and the the content needs to be technologically advanced. You also need to consider all the collaborators that you're going to be working with. And every content you create has to have a situation where content gets reviewed, and we have to always ensure that the content remains relevant and remains up to date. So you'll be basically stuck doing all of those because it's your content. You're responsible for all of that. So some of those challenges makes it difficult for people to actually want to create their own content, despite the fact that it's probably more guaranteed that you get what you want. And there is potentially something better out there that you can just share rather than creating your own content every time. So this is something I just wanted to share. The other question is, so you have the idea of some content. What's the right platform? How do you develop this content? Should it be an infographic? Should it be an algorithm? Should it be a podcast? Should it be a webinar? And they're all correct platforms for the correct audiences. For example, I was just looking at this at our LA County EMS agency, and we're looking at specific resources for our paramedics. And it seems like they would love if there were just a pocket card that they carry with them, and as they need it, they use it. The idea of getting engaged with a webinar or podcast is a little bit less of a immediately available to them. So if you know your audience, then you perhaps create your platform based on what your audience is interested in. And to do that, you probably need some feedback ahead of time from that audience. So it's important to know, while you have all the abilities to create different platforms, and content is out there for every platform, but not everything is right for everybody. So I wanted to just show you an example of our content area for the knowledge management domain. As Corrie was mentioning earlier, this is our pediatric education and advocacy kit. That's our public facing part of our education for the knowledge management domain. As you can see, is laid out really nicely, organized by what audiences it's intended for. It's color coded by what kind of a format it is. And we have a variation of different formats, and we are constantly looking at feedback from what was the engagement with something that took 30 minutes to review, and what was the engagement with something that took 2 minutes, for example. So we're constantly reviewing and learning from what we're putting up there. And then, every time we want to create content, we need to storyboard it. We need to make sure that it has been vetted by multiple stakeholders, and it's not just what I want to put out. There needs to be something that a group consensus agrees on. And this is just a few quick slides just to show you, this is what a storyboard kind of framework looks like for us as we're developing storyboard for a video, for example. As you see, a lot of details goes into how it's scripted. It is very meticulously and carefully scripted to make sure that the content actually flows in the right way. It's professionally kind of developed at the end. The end user will be able to get the maximum benefit from it. And this was a video, and I'm not going to play the video in the interest of time, but this is a video that exists in our peak for status epilepticus. It was a nursing simulation video. Most of the talent in there were nursing. And we did the storyboard, like I just showed you previously, to develop this 7-minute long video that basically shows you how to manage a patient that walks through the emergency entrance with status epilepticus from a standpoint of nursing tasks. So this is done by nurses for nurses, as an example. This is a couple of examples of the kind of infographics that we are putting up there on our peak area to just show simple, ready to use, just in time, takes a minute just to review, and is best used in the clinical environment. This is an example of a video podcast that we did for one of the PCARN studies on multi-center evaluation of pre-hospital seizure management. We also have audio podcasts, audio-only podcasts, but this is an example of one that was a video interview. We also created learning modules. There's the one that we developed on pre-hospital pediatric seizure, and that's about an hour module, but it's broken into pieces that it can be easily viewed in sections as people. Like, this is one of the best things we have out there. And the person who created this, Dr. Denise Whitfield, she's the director of education for the LA County EMS agency, and she's amazing at creating these. So if you go to our sites and see these learning modules with Denise, just remember these are great, and just take the time to review them. This is a just what Corrie showed you. This is an example of our algorithm. And this algorithm was developed, as Corrie mentioned, in collaboration with Trek. This is the first time that we actually co-developed or co-edited a version of this. In the future, we're going to be working with them to actually co-develop other content. For example, currently on mental health and things coming up with pain and sedation and child abuse and maltreatment. So what we learned is that we need to collaborate early. We need to get the stakeholders involved early. We have to leverage all of our relationships, and we have a lot of relationships, including a lot of our partner organizations that I'm going to talk about in a minute. Focus on your purpose, why you're doing this. Make sure that your content is appropriate for your audience, and also research potential existing content through your network. For example, we created a pediatric readiness toolkit for LA County, and we put a lot of content in there that we felt were good for individuals within the LA County area to look at, but 90% of what we have can be used by anyone. It doesn't have to be LA specific. So even though it was created in LA, it might be perfectly appropriate, a lot of it, for Wisconsin. So just remember, within your network, there are things that are being created by other states, for example, and by other entities. So it's good to have a network of collaborators that can tell you, hey, you know, by the way, I know there's something like that being developed in Hawaii, for example. So it takes away a lot of the redundancy in the work and makes you able to create content that is already vetted by other audiences.
And then Mo, Pat had a really great comment in the chat as well that, you know, putting it on the website is not enough. If you put it out there and you think it's amazing, you know, the folks aren't going to necessarily come to you, but need to think about how are you disseminating that message, and that will segue well into the end of this talk as well.
Yeah, absolutely. And I have a little on that in a little bit. Again, this is just showing you the area of the website, the only area of the website that's not public domain. It is the area for the early access. So all the content that we develop gets put on this early access area. There are individuals who are signed up to be reviewers. They review the content. They basically grade it for us. And if their review is not good, the content will never be published. It will stay in the non-published area. If content can be tweaked a little bit and make suitable, then we'll make the tweaking, and then we will publish it once it's acceptable. And if content is deemed as being acceptable and getting a good review, then the content will be published as is. And one of the things here is that we learned that asking people, hey, we have a bunch of stuff for you to review, can you go and review them, is not useful. You have to say, I want individual A to review item 1 and 2. I want individual B to review item 3 and 4. So we significantly improved our review process by assigning the review to the individuals and not asking them to do more than 1 or 2. Because the old way, again, this is lesson learned talk. So we're talking about what we did in the beginning that didn't quite work out by just saying, hey, go ahead and review. So this was a very important lesson learned, that our reviewers basically need a focused, I want you to review this. And then the next thing is the dissemination implementation. And Marc, whenever you want to jump in, this is more of the area that you're closest to. But so remember that you want to disseminate your content. You have to look at what channels you have available to you. And as Pat had mentioned in the comment, the website is a channel that is available to you. You also have social media channels. You have emails that you can attach stuff to. And as you can see, it's a big country, and there's diverse needs and there's diverse engagement. Some people are very engaged or easy audience for you, and some are very, very difficult to convince. So you have to kind of know who you're dealing with and try to establish as much collaborations and network as possible to reach the hard to penetrate group. This is just a quick, I have this slide on a lot of my talks, and our group does too, just to show that we want a centralized repository where all of our content goes. In this case, it's our website, and you see the web link in the bottom. We wanted the website to be not only a central repository, but we want it to be easy. When you go there, look, it's very intuitive to follow. We want it to be responsive, so first of all, it's responsive to your feedback. And second of all, it's responsive to whatever screen you're using. It shows the same way if you're using it on an 85-inch Microsoft, what's that called, the Surface Pro, or if you watch it on a little phone. It still doesn't cut in the corners. It still shows the whole section. So we wanted the website to have all of those qualities. And as I mentioned before, our PEAK, the Pediatric Education and Advocacy Kit area, is also under the Education tab. I put a QR code here for anybody who wants to just click on that, takes you straight to the PEAK page. So you can see some of the content. As if you go there right now, you will notice that our current one that will be for this current time, the mental health, has not been published yet, but we're hoping very soon after this meeting, we'll be able to start populating some content on mental health through our PEAK. Website needs analytics. We actually can be very purposeful about what sort of data we're going to collect. Most importantly, we want to know what are areas that people have been more interested in, most viewed content. There's also the option for you to be registered, to be a registered member of the website. Registration basically gets you access to email notifications when we have new contents put up. Also, you get a transcript of the activities you've had. So you'll be able to track what pages you have viewed. But none of the content, except for what I mentioned in the early access program, requires login. You can basically go in, you don't have to be registered, because we realize for some people, the additional steps to be registered may be a barrier. Also, perhaps collection of password information and things like that, maybe some people may not be comfortable with. So we are allowing for all of our content to be open to public. Just the registration gives you some customized experience, for lack of a better analogy. We also are very, very grateful for our partner organizations that we have 5 of them now. In the EIC 1.0, we only had ACEP, AAP, and ENA, but now we've added the SEMSO and ACS. As you can see, between all of those, there is 250,000 plus members that we can reach out to. So that they're not just our partners in disseminating content, but they're also helping us get the word out through other methodologies. Like, for example, you see these 2 little examples of during EMSC week, ACEP put on 2 webinars about pre-hospital pediatric readiness and hospital pediatric readiness. And each one of those had more than 300 people registered and watched those and listened to those webinars. And this is, again, another example of how the word gets out to our partner organizations through their newsletters, through their social media sites. So those partnerships are incredibly valuable and important to us. Then we have the EMSC Pulse, which used to be basically a newsletter, very static. It came out on, I think, monthly basis or so. It has completely been redesigned now. It is a web format. And since it's been redesigned, thanks to Emily Lemiska, our Director of Communication for EIIC, it's having much better engagement now. We've had 400 plus new subscribers just in the past few months. Initially, there were only 50 or so subscribers. And as you can see, it is very well set to put news information and updates. And as you can see, the last item, for example, is the Manish Shah winning the grant for the pre-hospital status epilepticus, the one that I did the interview with for our PEAK. This just shows you all of the different channels and how it reaches. I'm not going to go through this, but as you can see, we have multimodality communication with our audiences, internal and external audiences. We actually do have a hierarchy of audiences. We have our EMSC stakeholders and HRSA as our internal audiences, and the frontline providers and stakeholders being on the external, but we communicate with everybody. So what we learned is the concept of phased implementation. I think this was brought up earlier by Pat. You don't just put something on the website and call it a day. You first have to put it up, then you have to keep referring to it and let people know it's there over and over again. Use your multiple channels to be able to access people, to share this with them. Sometimes we have things like learning management systems that we have with Open Pediatrics and Target Solution, etc. And you will check, you need to check and see that people access the content But as I'll say in a minute, just accessing content is not sufficient. You can't just say, okay, so many people watched and that's it. So the next order of business here would be the evaluation, the review part. So thanks to Marc for sharing this slide from the Kirkpatrick's learning behavior, that it's important that first the learner gets the experience of what it is that you want them to learn. They need to really, really have it sink in. They have to believe it. They have to be able to show it to others. They have to be able to start practicing. As a result of this practice, they need to eventually change their behavior. And once they change their behavior, they start practicing differently with the new evidence, with the more robust practice. But then the last thing and the hardest thing is to measure how all of this impacts patient outcomes. And if you talk to anybody who's looking at this entire effort that we are all doing, is what is the impact on patient outcomes? Just because you have all these fantastic things, if you don't get that link to patient outcomes, then it's not as meaningful. So it's very important to have strategies in place to ensure that you're constantly keeping in touch with individuals to help them get a change in practice, which then ultimately affect the outcomes. So what we learned is lesson 6. It's a long road between accessing content to change in practice, and it's an equally long road from change in practice to showing outcomes. And this slide shows us our network of communication that we have through the EIC knowledge management domain. We work very closely with the other domains within the EIC. We use our EMSC Pulse more and more now as a channel. Our EIC website is a center for our content, and a lot of the other domains are using it robustly, as you saw this morning, for example, from a pre-hospital group. It's a very important presence, and we're very active with the EIC knowledge management domain in, as Corrie mentioned, upkeeping that and making sure that's working. We also have
definitely a two-way street, Mo. I think I'd add here too. We have one-way arrows, and I've always been wanting to update this slide because it's definitely a two-way communication street. And
Yeah,
really,
yeah, and Corrie, yeah, just to bring up with this group, and if people have any ideas, I think that we've heard some great ideas on other mechanisms. So one of the things that Denise Whitfield and Marion Gauchel-Hill brought up based on their experiences with the teams in LA were that, people, if I use the analogy of the store that people go to buy their books or to get their content, they're already going to Starbucks, and to try to convince them to come to our store front is a bit challenging, but we have actually made some nice inroads with partnering with some of the established brands in the pre-hospital setting, where our content can be hosted and will be hosted within their store or library that will be free and open for people to use, but it's basically a book that we're providing them, that we still have the intellectual property. It still can push them back to our website. But I'd love to hear from individuals, on this call and or in the future about other opportunities we're missing, because I describe part of our goal is to get into all of the eyeballs and ear holes of the people that say, oh shit, I don't want to take care of kids, I'm afraid of kids. Like, those are the people that we want to actually get into their brains. I think that we're doing a pretty good job about the people that are coming to look for pediatric stuff. So I'm just curious from this group if people have any things that come to their mind about how to access how to sort of get into those people's faces or eyes or ears.
Yeah, Marc, and thanks for mentioning that. I kind of went through it pretty quickly with Open Pediatrics and Target Solutions and Advanced Problem Solvings. Those are the learning management systems that we are partnering with, that we are able to put our learning modules on their platforms free of charge. And what they get out of it is that there's more offerings that they have for their audiences, and they are very established and broad audiences. So thanks for
yeah. And then anybody else on the call, you said, oh wow, seeing this presentation, and I know we presented parts of this through town halls and other forums, But is there anything that you said, aha, we should be trying this. Why don't we do this? Any aha moments during this talk? We'd love to hear them either in the chat or open dialogue. km@improvement.center is our address that you can reach any of us. So I just wanted to throw that out there as well.
Candace, I don't know if you can speak or not. I see your text. I just wanted to hear a little bit more about what you meant by trying this at your upcoming advisory council meeting, because certainly our advisory councils and our PECs could be a great method, but I'm just curious how you would frame that.
Hi, thanks. Yeah, this is Candace. That lesson 5 of it's not enough to have your resources, that we need to share them and be referring back to them. I just really like that. And it seems like something that I can incorporate that's really simple, that will really hopefully create more engagement. So I was thinking of like adding websites of things that I'm referring to when I give updates in my council meeting, like adding the website under those agenda items, hoping that'll get people a little more engaged, and maybe including like just different links of resources, maybe like in the footnotes or somewhere in those documents that I already distribute and share, because I already have an engaged audience. So why not plug into something else that we can refer people to get more engagement?
Thank you. That's really helpful. And from an educational perspective, this concept, and Pat mentioned it, of distributed learning, that most of you will forget 99% of what we've just talked about. So that's why we're going to hopefully get you to go to the website to re-engage with it again. So we call it learning curves often, but I think we forget that there's something called a forgetting curve, which is actually much steeper. It's harder to retain things. Yeah.
Yeah,
and I just wanted to add, sorry, I just wanted to mention that Pat had just put in about the QR codes. Just remember, one of the keys with the QR codes is that QR code refers to whatever link the information is on. So if you're not using your own content and you're linking to somewhere else, it's very important to keep on it, because links can expire, pages can be moved, and then you'll have all these QR codes that are giving you a 404 HTTP error or something like that. To the best of your ability, if the QR code can be to something that at least you control or has a life that can stay on and doesn't get kind of taken down without your knowledge, that will be very important. But QR codes are a great way to do this. Just wanted to add that. Thanks. Sorry, Corrie, I didn't mean to interrupt you. You were going to say something.
No, you were perfect. And what I was thinking, just in regards to what Candace said, is then that link's there, right? So they might not need that education today and go look it up, but then they're like, ooh, they talked about seizures and one of, what maybe it was the February meeting, and then go back to those links. And so they'll have those for references. We do, just in our last couple of minutes here, want to introduce you to the rest of our KM team. So Mo, if you want to advance to those slides. Yeah, so we would be remiss if we didn't have a chance to, next slide, to introduce you guys, and well known to the EMSC community. Robin Goodman's our invaluable nurse manager. Emily Malamiska has been revolutionizing communications, how we think, not only throughout the EIIC, but throughout EMSC, and has been a fantastic team member. And then Marc Vasquez, as I said, is our knowledge broker here at Baylor College of Medicine. And project management expertise, and has been helping to run the EMSC Scholars Program. And then our latest and greatest addition is Brad Soboleski. So Mo, if you'd want to just talk a little bit about what we're doing there with the podcast director role.
Yeah, I can comment on that, Corrie, real quick. I think that
yeah, I was going to say, Marc, you do.
Yeah. So I think we're still trying to figure this out, because we recognize that there's a lot of podcasters out there, and particularly with my comment before, that people have their favorite shows. So one strategy was to try to create our own production company, and this is the way that Brad framed it. He's like, we can try to create the next Marvel series, or we can try to create a new character on Marvel. And I just love how he framed that, and potentially in the future having our own series. But for now, we have created some of our own podcasts and are going to partner with others to get this sort of on their channels. And we've done that already. And we are also going to be getting information onto those shows. And our goal over the next year is actually to have what we're going to call the greatest of all time, or the GOAT podcast, where all podcasters ideally are getting wrangled by Brad to cover a hot topic in pediatric emergency care and really generate a lot of enthusiasm about a topic such as pediatric pain this fall. So be on the lookout for that. And thank you to Brad. I don't know if he's on today, but we're really excited to have his expertise. This is not coming from his specific podcast. It's actually trying to bring together the diverse podcast community. And if you're familiar with any podcasts, particularly nursing or pre-hospital ones, please send them our way. I think that there's a lot of great hospital-based podcasts that are consumed very highly, but we have struggled a bit more with finding, those sort of industry leaders for pre-hospital and for nursing. So thank you for staying a few minutes over, and great job, Corrie and Mo. Thank you guys for leading the session.
Yeah, thank you, Marc, for moderating. This was sort of ad hoc when you got this role, but you did an amazing job. Thank you so much. And thank you all of you guys for joining us. My understanding is that this session will be recorded and available. I know we covered a lot, and there's limited amount of time, but most importantly, if you guys need to reach out to us, km@emscimprovement.center. I had it on the previous slides, but it's not close enough for me to go to, but just let us know if we can help you in any way, or if you have any questions for us. Thanks again, really appreciate it.
Thank you, everyone. Enjoy your break.